Yeah, I think she started recording
Started
already.
recording. Okay. So thank you guys. Welcome to the I think not years, my years, last CME. And like I was saying, that we've got a stellar cast who we couldn't have a better cast of characters who are taking us home. They are beautiful, top-notch speakers, and they're going to take us over the line, so to speak. And great topic which Pavan Panchavati has put together. Tarak Vasavada couldn't be here today. He's traveling. He will try to join, and the Pavan will be taking over and conducting this. I am in Tampa right now, trying to put finishing touches to the convention. So really ask for your excuse to have Pavan carry on. And if I can, I'll join back in a couple of hours to give you farewell remarks after this thing is over. Again, thank you again for all your support and prayers and blessings and good wishes all throughout the year. And I request all of you to join the convention coming up. We'll have a great time. rpconvention.org, very easy. That'll give you all the information that you need. Thank you so much, and namaskar.
Thank you, Amitji. I'll take over from here. I'm going to
Thank you.
share my screen.
Pawan, I just want to say quickly, thanks, Amit, for your leadership, and thanks for bringing us speak, because the best is always the last.
Okay, Murthy, thank you. Hey, can you see my screen full? Can you hear me okay? Murthy, can you?
Yeah, I can hear you well.
Okay. Yeah, welcome everybody. Thank you for joining us. It's an interesting way how we linked up with Dr. Kishore and Dr. Murthy, and we wanted to get this CME going. The title, we thought about it and we said, let's do the title as the Reversal Revolution, an evidence-based lifestyle medicine for cardiometabolic risk reduction. And I'll be talking about the metabolic syndrome epidemic. I'll try to compare it with India and USA. And Dr. Kishore will be talking about lean diabetes, and Dr. Murthy will be talking about type 2 diabetes reversal and remission. So let's get started. And before we start, please fill out that CME forms and the survey. And I think I talked to the EMED events people. We put in a lot of effort to get this CME going. You'll get a CME certificate within a week. So what we noticed as per Dr. Vasavda is that we've not been filling out the survey forms, and out of 60, 70 participants, we're only doing like 10 to 15. So please fill out the survey and get your CME. Okay. Okay, so let me give you a quick introduction of my topic. It's metabolic syndrome epidemic, India versus USA. My name is Dr. Pavan Panchavati. I'm a practicing hospitalist and a family practice trained physician. I'm a clinical professor with UAB for the past 10 years, and I'm boarded in lifestyle medicine and obesity medicine. And I'm fortunate to be a part of API Academic Affairs Chair for this year. And also I'm a deputy editor for JAPI, which Dr. Kishore is the editor-in-chief. Right, in the next 20 minutes, we'll explore why metabolic syndrome completely is different depending on whether your patient is from Southeast Asia versus US, and why this difference has life or death clinical implications. Right, I have no financial relationships or conflicts of interest. Content is all evidence-based, and statistics are drawn from peer-reviewed sources. Right, so the learning objectives for today, the 5 objectives is, let's define metabolic syndrome using NCEP, ATP3 criteria, and IDF criteria, and understand why they differ for South Asians. And let's compare the prevalence between India and USA, and try to unpack the thin fat syndrome. Let's examine the lifestyle drivers for both the contexts, and let's try to leave with practical, actionable management strategies. Right. So let's try to define what a metabolic syndrome is. A metabolic syndrome is a cluster of five interrelated abnormalities, which includes the central obesity, the hypertension, the elevated blood glucose, the high triglycerides, and low LDL that dramatically amplify the cardiometabolic risk. So it's usually diagnosed when three of the five criteria is met. But these five components share a common root, that's the insulin resistance. So treating each in isolation without addressing the root is like bailing out a leaking boat with one cup at a time. So our goal is to address the insulin resistance. That's the main key here. And the downstream consequences are of metabolic syndrome include a 5 times increased risk of diabetes, and a twofold to threefold elevated heart attack and stroke risk, and high risk of fatty liver disease and progressive chronic kidney disease, obstructive sleep apnea, and emerging associations of cancer through the hyperinsulinemia, mainly your colorectal cancer, the breast cancer, and endometrial cancer risk. Right. So let's use two criteria, try to contrast and compare them. So the two frameworks we have is the National Cholesterol Education Program criteria, which most of the US trained physicians learned, which requires any three of the criteria with the waist cutoff of 102 centimeter. Uh, Sorry, somebody came in. Okay. Uh, the waist cutoff of 102 centimeter for men and 88 centimeter for women. The International Diabetes Federation criteria adds two critical differences. What we have to observe here is the central obesity is required here and is mandatory. And the waist thresholds are ethnicity specific. For South and Southeast Asians, these cutoffs drop to 90 centimeter for men and 80 centimeter for women. Why does this matter? A South Asian male with a 92 centimeter waist with elevated triglycerides and borderline glucose has metabolic syndrome by IDF criteria, but it is totally missed by the ATP3 criteria. In primary care, we are systematically undertreating this population by using the wrong tool. This is not technicality. It changes who you screen, who you counsel, and when you intervene. Right. So let's try to see the prevalence. I think this is one of the most important slides. The studies of urban India population suggest that the metabolic syndrome prevalence is approaching about 45 to 55%. That is pretty much 1 in 2 adults in Indian cities, urban cities, are affected by the metabolic syndrome. So the rural India comparably is lower, around 25 to 35%, but the urbanization is rapidly closing that gap. Right. If you see the other side of the slide, we see that in USA, the prevalence sits about 22 to 35% overall, with higher rates in the Hispanic and African American population. Right. If you look at the bar chart down there, it makes it very clear that the India's urban rate outpaces US. Even the highest US subgroup estimates India is beating them, the urban population is beating it. And the India's trajectory is rising substantially higher and faster, while the USS has become to plateau. So the USA chart, if we look at it, has looks like a chronic epidemic, but the India one is like totally accelerating. Right. Now, the most important slide of my presentation, which Dr. Kishore will probably expand more, is the Asian Indian phenotype or the thin fat syndrome. It's, a South Asian patient who presents with a BMI of 23 is technically normal. You don't measure the waist circumference, you see borderline lipids, treat the numbers, and move on. You've just missed a metabolic syndrome big time in a patient who is at very, very high risk of cardiovascular risk. The reason is body composition. South Asians carry disproportionately more visceral adipose tissue and less skeletal muscle tissue at any given BMI. That visceral fat drives the insulin resistance and atherogenic dyslipidemia. The muscle deficit, what happens is it worsens the peripheral, the muscle deficit definitely worsens the peripheral glucose uptake or disposal, right? If you look at the study of the Interheart and the GBD 2019 data that indicate that the South Asians have substantially higher cardiovascular mortality at equivalent BMI compared to Europeans. That is why the BMI overweight threshold for Asians is 23 and not 25. Right, so we looked at some of these slides. I didn't mention, there's a genetic defect, sorry, the gene linked to this Asian phenotype. Right. So let's look at what are the risk drivers? Let's compare Indian risk drivers with USA risk drivers. In India, the dietary shift towards high glycemic foods, the white rice, the refined flour, the fried snacks, and low fiber intake. Physical activity totally has collapsed as the economy is moved towards the IT and service sector jobs. We can order food from the food companies within 10 minutes in big cities in India, and everything is fried and refined food. So it's just a lot of problem there. So adding to that, a lot of psychological stress in big cities. Is a lot of stress to achieve more, do more, work more in big corporate companies, and it's combined with chronic sleep deficit, and of course the rising alcohol consumption in urban areas. Layered around a genetically susceptible background will make it very, very, very high risk drivers in the in Indian community. So when we come to the right side, we're looking at the USA risk drivers, the ultra processed foods, the sugar sweetened beverages, and supersized portions, and car centric built environment, which has eliminated whatever the activity they have. So around 40% of the US adults have obesity. Racial and socioeconomic disparities in metabolic health are tied directly to the food access. Walkability and healthcare equity. So both are different drivers, but the same metabolic outcome. Look at this chart for a second and then go to the next chart. Right. So the cardiovascular outcomes is very, very early onset in India. So we did a study actually in Huntsville with the hospital we have. We tied up, and what we did was we screened about 80 to 90 patients of South Indian origin, I mean Southeast Asian origin, mainly the Indians. And we found that we did a CT coronaries actually, and then what we found was about 40% of asymptomatic patients had coronary artery disease. Of them, very healthy people, very thin guys, people who were doing marathons. They went, and some of them had to have a bypass, some of them had to have stents. Let's try to understand that. It's just a pretty impressive scores. We screened only about 80 people, and then of them 40% had to have some form of intervention and had cardiac disease. So the consequences of under treat under treatment of the metabolic syndrome are very, very measurable. The data suggests that Indians experience their first coronary event approximately a decade earlier than their Western counterparts, often in early 50s. So studies show that there's a 2 to 3 fold greater risk of stroke with metabolic syndrome, as we discussed in the previous slide. The cardiovascular disease, of course, remains the leading cause of death in both USA and India. So if you look at it, the average age of heart attack in India is about 53, and in USA about 65. That's almost like a 12-year gap, which is like a decade gap. So that's a generation, and it is happening to a patient who, if their clinician, uses the NCEP criteria, and not use the IDF criteria and does not measure their waist, they were never flagged as high risk, and these people are the ones who are going under the radar. Right. So I'll try to touch briefly about the prevention and management strategies. So of course, for everything, the lifestyle intervention is the first line, and it's not optional. So the diabetes prevention program and India's diabetes prevention program one trials both showed that modest weight loss, about 5 to 7%, uh, associate, and along with the dietary changes of eating mostly plant-based diet and about 150 minutes of moderate activity, significantly reduce the metabolic risk and also decreases the diabetes incidence. They did a trial in which they did analysis and which says that the lifestyle medicine outperforms metformin for prevention. Right. So when we require, if you look at the right side of the chart, if we need the pharmacotherapy, GLP-1 agonist, the SGL2 inhibitors, and metformin are the evidence-based options we have. And for South Asians, mostly, we deploy this based on the cardiovascular risk and not BMI. So let's assume that a South Asian comes in, to our office with a BMI of 24, with metabolic syndrome and high ASCVD risk may warrant early pharmacotherapy that a US guideline using BMI alone would not yet trigger, anything. So we have to be very mindful about this population. So the country specific priorities, if you look at it, what India needs is lower the screening thresholds, and urban walkability is there. Then there is the Ayush integration going. It's a very interesting subject. We met somebody back in Bhubaneswar who was doing the Ayush. I think they're coming too. So the integration is also good. I think Dr. Murthy will talk about it later in the talk. Right. For the USA needs equitable access to obesity pharmacotherapy. I think GLPs are exploding in India too. So a lot of clinicians have an option to use the GLPs too. Right. So key take home messages here, what I wanted to briefly touch on is, the number one, India's epidemic is very steeper and earlier, and we cannot compare it with the US or treat it like the US epidemic. So the thin fat syndrome is real, and measurement of waist circumference and using International Diabetic Federation criteria is the key to South and Southeast Asian population when they walk into our clinic. The third is the lifestyle medicine is the first line, and it's not a soft medicine. When it is used correctly and the patient takes it in the right way, it is not a soft medicine. It is a very, very powerful tool. And the number four, what we wanted to talk, we have been talking is we don't want the patients to be obese to prescribe, and especially in the Southeast Asian population, we use the cardiovascular risk to guide pharmacotherapy in our Southeast Asian patients, right? So the last key take-home point I would say is the social determinants are the clinical determinants. So I sign off here, using my key take-home messages, and we will take questions at the end of the three sessions. I just forgot to mention that, and I'll let Dr. Kishore go after me now, and till he gets his slide share, I'll start introducing him. Thank you all again. Dr. Kishore, you can come on. Right. Before Dr. Kishore puts in his screen share slide, I want to introduce him. He is a mentor, and Dr. Bellamkonda Kishore is an academician, is an innovator and entrepreneur. Currently, he's the adjunct professor of internal medicine at University of Utah Health in Salt Lake City, Utah. For 2 decades, he's been served as a principal investigator in Department of Veteran Affairs. His research focus on purinergic signaling as it relates to obesity and metabolic syndrome and diseases of kidney, liver, and heart. He developed and patented innovative therapies and launched a startup to commercialize them. In recognition of his innovative work with commercialization potential, Dr. Kishore has been inducted as a senior member of National Academy of Investors. Dr. Kishore is the founding editor-in-chief journal of API. He recruited me, and he's going to be talking about lean diabetes in depth and emerging global health challenge. Thank you, Dr. Kishore, for coming to API and speaking to us and educating us. Thank you.
Thank you, Dr. Pawan Panchavati and Dr. Tarak Vasavara and Dr. Amit Chakravarti for giving me this opportunity to talk about lean diabetes. I can tell you one thing. 10 years ago, when I was looking the American Diabetes Association annual, annual report, I could not find the word lean diabetes anywhere in that report. Now today, it is one of the rapidly growing form of the diabetes throughout the world, not only in the Indian subcontinent, also Africa, but throughout the world, as you can see right now. So I got a disclosure. I'm the co-founder of a startup biopharma, trying to develop medicines or new therapies for diabetes and kidney diseases. And of course, my presentation today has nothing to do with my commercial activity. Thank you. Now, the learning object is at the end of this session, the audience will be able to explain what is lean diabetes and its epidemiology, and they should be able to delineate the origin and prevalence of lean diabetes, and to learn the contribution of COVID-19 to lean diabetes, and to explain the pathophysiology of lean diabetes, and to describe the clinical management of lean diabetes, and to describe the preventive aspects of the lean diabetes, as well as to evaluate the fetal programming of cardiometabolic risk and its prevention. This is an emerging science, and there's a lot of evidence accumulating that the cardiometabolic risk is programmed, not in the adulthood, right in the fetal stage, and depending on several factors such as mother's maternal nutrition. So what is lean diabetes? We all know that overweight and obesity are established risk factors for type 2 diabetes mellitus, but however, a significant proportion of diabetic patients are normal or underweight as determined by their what you call best body mass index. And these subjects have lean diabetes, we call, and is also known as atypical diabetes or malnutrition related diabetes, tropical diabetes, and in India they call it mostly type 5 diabetes. The lean diabetes does not meet the American Diabetes Association or World Health Organization classification of type 1 or type 2 diabetes mellitus. And lean diabetes is more like a hybrid of type 1 and type 2 diabetes, as we can see in the following slides. So if you look at the epidemiology of the lean diabetes, it's predominantly seen in men of Asian or African ancestry, and geographically in tropical countries, including the Indian subcontinent and sub-Saharan Africa. And also it's predominantly seen in low or middle income socioeconomic status with a history of childhood malnutrition, although that's not a prerequisite in the recent years. And about 80% of the lean diabetics in India are from middle income group with no evidence of dietary protein deprivation. And if you look at the current prevalence of the lean diabetes, most of them are in the South Asia, Indian subcontinent, and sub-Saharan Africa. But in the recent years, we see a steady increase in the Europe and North and South America, mostly due to the changing demographics with the immigration and other factors, people coming from other parts of the world and settling down in these regions. But if you can see, they say throughout the world it is affected. It's not just restricted to one part of the world. And this is interesting. And this the paper published in Diabetes Care, which is the American Diabetes Association publication, between 2015 and 2020, that is before the pandemic. If you see, the largest increase in the diabetes in the United States here is in the lean diabetes. 17, almost 18% increase is in the lean diabetes, but not the obese adults. So the problem is right now here we have this problem imported or whatever you call it. We are having this problem right now in the United States. So another thing is, after the COVID, we have a lot of new onset diabetes. After COVID, we call NODAC. And COVID, how it causes diabetes in a person who doesn't have any diabetic history before. Of course, SARS-CoV can directly damage the beta cells, reducing the insulin secretion. It can also cause a lipotoxicity and oxidative stress, leading to hyperglycemia. And also the inflammatory cytokines produced due to SARS-CoV can also affect the insulin resistance, cause the insulin resistance through the lipolysis. And so ultimately, SARS-CoV, COVID, has induced diabetes in many patients, but most of them are recovered. But at least 50% of the patients developed diabetes mellitus to varying degrees. So the COVID-19 has added to the burden, to the already increasing burden of the lean diabetes in the United States. So what are some of the salient features of lean diabetes? It's an early life nutritional insult. The history is there always, most of the time, which affects the cardiometabolic programming. And of course, there is genetic susceptibility. You can see mostly in Asian or African origin, and visceral adiposity, as Dr. Panchavati said, at the low BMI, that is important. And also beta cell dysfunction is predominant in these people, and as compared to the insulin resistance. And the gut microbiome also plays a role in regulating the metabolic inflammation. And there is also evidence that coming from mostly Africa, the epigenetic transmission, if one generation is exposed to famine or starvation, 2 or 3 generations down are showing the same type of phenotype like a lean diabetes. So there is some type of epigenetic transmission is also there. So lean diabetes, if is multifactorial, we have genetics, we got epigenetics, we got the environmental factors, and also lifestyle, which Dr. Murthy Gokula will explain later. Now, there is a fundamental difference between the European phenotype and the Indian phenotype or Asian phenotype. So if you look at the fat mass, both may be having the same, more or less the same fat mass, the white jacket. But if you look at the lean mass, the muscle mass, the Europeans have proportionately more, whereas the Indian type has less. So the ratio is important. How much fat is there related to the lean mass? That determines the cardiometabolic risk and also lean diabetes. Now, if you take these European and the Asian populations and plot a graph, lean mass versus the fat mass, you can see they're distinctly two different populations. You're not dealing with one; they're different populations with a different susceptibility to develop lean diabetes. Now, this is a practical example. Here we have two doctors. Dr. Yudik is an endocrinologist in UK. Dr. Ajnik is an endocrinologist in the KM hospital in Pune. They have been working together for several years on the cardiometabolic risk, and they made an interesting picture of themselves. Both have a BMI of 22.3 exactly. But if the DEXA scan shows that Dr. Yudik has 9% fat, whereas Dr. Ajnik has 21%. This is the difference between the European or Caucasian phenotype and the Asian phenotype. You may be slim in Asia, but you're already obese metabolically. That's a problem. Now, what is the reason for this major difference between the Asian or Indian phenotype and Caucasian? Unfortunately or fortunately, Indians have settled down in agriculture 11,000 years ago, much before the rest of the world, from the transition from hunter-gatherers to the farmers. And this change has resulted in gradual shrinking of the musculoskeletal system and also the body frame, the skeletal frame. And they started eating more carb-rich food instead of meat food or protein. And this has transitioned, they completely changed their phenotype to a more lean, what you call lean and a metabolically risky type of phenotype. So this is the basic problem why the Indians or Asians are susceptible to develop insulin resistance more easily. Even when compared to Chinese, the insulin resistance develops much easier, faster in South Asians. Now, if you look at the pathophysiology of lean diabetes, we said that the genetic predisposition is there. Insulin resistance can come very early. Of course, the visceral fat accumulation is another problem which can cause to insulin resistance and hyperglycemia. And the reduced muscle mass, as I said, is another thing because most of the glucose is metabolized in the muscle after brain, but brain doesn't need the insulin. But the insulin resistance causes and the lack of muscle mass results in the less burning of the glucose and impaired insulin resistance, and then you got the beta cell dysfunction. All these things add up to the hyperglycemic state in the lean diabetes. Now, as I already said, lean diabetes is a mixture or a hybrid of type 1 and type 2, because in type 1, we see predominantly insulin production is low as compared to the insulin resistance. In type 2, we have insulin resistance more than insulin production, but in the lean diabetes, they are more or less equal in proportions. The key features of lean diabetes, of course, visceral fat, which has already been described, accumulation of, and we Indians have the tendency to accumulate fat in the liver and pancreas before we can see the abdominal fat. That is a really risky thing. And of course, there is severe hyperglycemia. Both fasting and postprandials are much higher than the type 2 diabetes patients. And they also can develop microvascular complications earlier or even severely. And of course, genetic abnormalities can be found in this. Some of these patients can develop or show evidence for other genetic abnormalities. Now, the cardiometabolic abnormalities to be considered in these lean diabetic patients, we already talked about these things. We got the standard high blood pressure, fasting triglycerides high, low LDL cholesterol, and high blood glucose as compared to type 2, and insulin resistance. We can look into the home IR and also systemic inflammation by looking in the HSCRP levels. All these things can be found in the lean diabetic patients easily. And diagnosis is the standard method. You need to do the anthropometric, not only BMI, like the waist and the height and the ratios and all those body parameters, and blood glucose testing. Sorry, both the fasting and the postprandial, they're much higher. And then if you have facilities for the scanning and you can do the body mass, DEXA scan or some type of imaging to quantify the amount of fat in the body. And then, of course, C-peptide assay can give the picture of the production of endogenous insulin secretion, or insulin sensitivity can be assayed, and also immunological or metabolic defects can be looked at. One has to look for other abnormalities such as immunological or metabolic defects. And all these things put together can provide the diagnosis of lean diabetes, which is not a difficult thing to do. And of course, there are many, as already discussed, anthropometric criteria, body composition, glycemic parameters, and insulin dynamics. This is very important because it's still not done routinely in many clinics. So hemoglobin A1C and fasting blood glucose are not enough in many of these patients because they will not give the real picture of the lean diabetes. Of course, there are maybe other features like non-alcoholic fatty liver disease and endothelial dysfunction leading to cardiometabolic risk. So the key takeaway here is metabolically obese, normal weight diabetes characterized by reduced beta cell reserve and ectopic fat in adverse body composition. That's the typical description of a lean diabetic patient. Now, we know that there are two types of features. One is metabolically obese normal weight and metabolically healthy normal weight. In both these things, the body mass index may be same, but the rest of the features differ, like visceral fat, fat mass, lean body mass, insulin sensitivity, liver fat, and serum. This is the standard checklist for each patient to differentiate whether they fall into the metabolically obese or metabolically healthy obesity or normal weight. Now, this is an emerging science. A lot of evidence is accumulating that cardiometabolic risk is programmed early in the fetal life and also in the infancy depending upon the maternal nutrition and also the nutrition in the early stages of the life, maybe less than 1 year like that. So the maternal nutrition can be maternal malnutrition or maternal obesity, or you can have maternal diabetes. All these things can affect the fetal programming. The fetal metabolic program occurs through placental transmission. So we can have a low birth weight or high birth weight children. Both are deranged cardiometabolic risk. And of course, this can be transmitted to epigenetic modifications. Then organ remodeling can occur early in the fetal development, and you can see them in the postnatal life with like a rapid child growth or and not having the normal parameters of growth. So in the long term, the children affected by this type of abnormality, when they become adult, they show hypertension, diabetes, cardiovascular diseases at a very early stage in their life. So what we are trying to change in the adult life is already occurred or changed, or something defect occurred in the, it's like a manufacturing defect, you can say, a product. So something has changed and we want to fix it by all means, by treatment, lifestyle changes, and other things. So the research shows that we need to go back and address the fetal development, not just trying to address the abnormality in adulthood. So how this happens is there is some scientific papers coming up showing that maternal milieu, like hyperglycemic, the mother is hyperglycemic, obese, or stress or inflammation is there. There is a placental interface through some hormones like 11 beta hydroxy and GLUT receptors, glucose transport receptors, and oxidative stress. They can actually condition the fetal programming, resulting in a type that can result in hyperinsulinemia and hypothalamus pituitary axis and inflammation and microRNA. These are very important. These microRNA can actually regulate many functions in the body. And the long-term outcomes of these things in the adulthood is obesity, type 2 diabetes, hypertension, and cardiovascular diseases. Now, the placenta is emerging as a key player in the cardiometabolic risk in programming the early stage. What you call exosomes. Exosomes are small vesicles that can bud off from the epithelial cells of placenta from it, and they can go either way. They can go to the fetal side or the maternal side. It's a bilateral communication. It's like sending a letter from mother to the fetus and fetus to the mother. The maternal environment, like gestational diabetes, obesity, preeclampsia, can result in the placental exosome production budding off from syncytial trophoblast, and it's bidirectional extracellular vesicle flow. And these contain biologically active substances like microRNA, and the fetus circulation can take up these exosomes, and these microRNA can cause gene regulation in the fetus. That's programming, and the outcomes are growth, metabolism, and vascular health of the fetus is affected or programmed to a risky type in the very early childhood or infancy. Now we got thin fat Indian baby, which Dr. Pawan Panchwat has mentioned. If you take a white Caucasian, average body weight at the time of birth is 35 grams, and if you look at the fat mass, is very little as compared to the muscle and viscera and other things. But if you take an Indian baby, it's 2,700 grams, 2.7 kilograms at the birth. But if you look at the fat, has a disproportionately higher fat as compared to the muscle and viscera. This is the problem we have, thin fat Indian baby. So how to prevent a thin fat Indian baby? We have to ensure the maternal nutrition is balanced, especially micronutrients. It has been shown that deficiency of folate during the pregnancy can actually result in the cardiometabolic risk in the fetus. So encourage more, and then physical activity, moderate physical activity is needed during pregnancy, and provide education to the mothers, expecting mothers. And so maternal health is very, very important. And we have not been focusing on this thing in India, at least. Unfortunately, pregnant mothers are eating all sorts of food diets which they're not supposed to eat when they're pregnant. Now, if you come back and look what is the normal weight or lean weight obesity, they're multifactorial. You got low birth weight, you got fat overflow, and you got tryptophan phenotype, maternal malnutrition, environmental factors and genetic predisposition. How to combat it? So it's so multifactorial. One or two remedies do not work. So the clinical management of lean diabetes, the primary goal is to reduce insulin secretion and reduce insulin resistance. Other therapeutic strategies are reduce visceral fat, especially in the liver, change the dietary regime, and increase the physical activity and exercise, which are common for type 2 diabetes. And pharmacologically, metformin, the use is limited in the lean diabetes unless the insulin resistance compound is stronger than the insulin secretion or insulin, then SC, the sodium glucose cotransporters, glyphrogens, they can cause euglycemic diabetic ketoacidosis, and this should be used with caution. And the GLP mimetics, they're offering some promise. At least 20 randomized control studies have shown promising outcomes. And the South Asian, what you call endocrinologists from India, Pakistan, Bangladesh, Nepal, they all met and they come to some type of consensus how to manage the type 2 diabetes, which is prevalent in those countries. This was published in 2019, and I could not see any follow-up after that. Now, obviously, the GLP-1 mimetics are not a long-term solution or practical solution in the countries like India. They're still expensive. It costs at least $3,000 per, I mean, at almost $10,000 per month, and which is not within the reach of many people. So you need to have a different type of approach in South Asia. So one of the things is lifestyle nutrition optimization, which Dr. Gokul will talk after me. One of the things that most people are not getting in India is micronutrition. It's not only B12, folate, vitamin D, also magnesium. Due to they are eating such highly refined foods, the chronic low-grade magnesium deficiency is very prevalent in India, and magnesium is a cofactor for many enzymes and reactions involved in energy metabolism. So there is a lot of things that are not systematically studied or documented. And the low-cost proven medications for the metformin can be used if the insulin resistance is higher. And of course, sulfonylureas are better and cheaper also, insulin secretion. And of course, the human insulin is another alternative. Then, of course, rational low-cost monitoring is needed. Hemoglobin A1C, more often it has to be done, and periodic complications for screening for complications also needed. And in the primary care, there should be protocols developed based on similar to the one that WHO has developed. And I don't know whether that's happening. Dr. Murthy can tell us. Task sharing is another important. And the using the non-physician workers is unlike in America, where the nurses and NPs and other things are involved in the follow-up of the patients. It's very hard for the physicians to follow up the patients in India. And targeted use of advanced testing, and of course C-peptide and autoantibodies testing and all these things. I think it's not done routinely. The key takeaways are the cost-effective care in South Asia is you have to preserve the beta cell function, and also the weight loss and loss of the fat in the liver. These are the key points that one has to focus. Now, there's a clinical study registered in the UK targeting the beta cell failure in lean patients with type 2 diabetes. Combination, they are looking at the combination therapy with the liraglutide, which is a GLP-1 agonist, and pioglitazone, an oral administered drug. And the basis is liraglutide increases insulin secretion power of the pancreas, whereas pioglitazone reduces resistance to insulin action. And I have not seen the update or the results from the study. It was registered a few years ago, I think, before pandemic. Now, coming to the GLP-1 agonists and the lean diabetes, of course, there are many benefits. They can reduce hemoglobin A1C, they can increase the beta cell function and glucagon, reduce the glucagon. And of course, the GLP-1 and GAP agonists are even better, the combination. Of course, there are some risks. Excessive weight loss is not good, leading to lean mass. It can cause loss of skeletal muscle, sarcopenia, and limited data is available from the GLP so far from the lean diabetes. There is no systematic clinical studies. The strategy is targeting metabolic control, preserve the muscle mass, and that's one thing that's difficult to do in the patients. And nutrition and resistance training is important. And therapy should be individualized based on the level of insulin resistance versus insulin secretion. And I published a couple of reviews recently, one in the JAPI, one on the lean diabetes, which you might have seen. And more recently, I published an innovative review on the physiological reports on the obesity paradox, which is another puzzle. When you look into the cardiometabolic risk, and there are some important observations from these two conditions. Now, if you look at the obesity paradox, what you see that obesity, we know, epidemiologically causes type 2 diabetes, mellitus, hypertension, cardiovascular diseases, and several non-communicable diseases. However, once the patient develops acute cardiovascular decompensation, it's the lean people, it's the obese people who survive, not the lean people. The risk of death is high when they are obese, not when they are, uh, the obese people survive better than the lean people. This is a puzzle which we call obesity paradox. But if you look, the same obesity can cause insulin resistance, insulin secretion decreased, body fat accumulation. However, in the lean of Asian and African ancestry patients, it's a lean diabetes, which is again a risky thing. And we see the risk here with the lean people, and we see the risk here with the lean people. And in both cases, what is important is cardiorespiratory fitness. What is cardiorespiratory fitness? And I don't have time to explain it. It's like the internal combustion in the automobile. You have the gasoline coming, oxygen coming, and the spark plug ignites, and the piston goes, and there's a power generated, and that drives the car. And the same thing happens here. If the cells in the body don't get enough oxygen and nutrients, they fail. And the cardiorespiratory fitness is important whether you are lean or obese. So the question here is being lean is a disadvantage if one develops serious disease. Okay, being obese is risky, but being lean is also risky once you have some serious disease or chronic disease. This is something that we are facing a puzzle, and there's no consensus, but there's a lot of evidence that being a lean is a problem sometimes. Now, what is the reason? So we had to go to the Rumsfeld's matrix. We know that there are things we are aware of and that exist and also understand them. We know that there are things that are existing, but we do not know and we don't understand them. Then there are many things which you don't know, and there are known unknowns and the unknown knowns, so we don't know much about the obesity, the cardiometabolic risk. So what we are doing is we are just oversimplifying. All the problems are coming because oversimplify, because we can't understand. And this is the problem we are facing today. And hopefully in the next 10, 15 years, the artificial intelligence will help us to understand it better. Thank you very much for your attention.
Yeah. Thank you, Dr. Bellankunda. So,
Thank you,
Dr.
sir.
Murthy.
Yeah, hi, good afternoon, everybody. And
Can you put on your slide while I read your intro, please? Thank you. And
Yep.
As a reminder, for all the people here, please fill in the EMED events survey for your CME certificate. They will send it directly to your email, and it will take about a week. That's what Dr. Vasavada told me, and we got it in the past too. So let me introduce the last speaker. Password request to start the meeting. Somebody. So 1 second, sorry, some notice. Let me introduce the last but not the least speaker, Dr. Murthy Gokula. His full name is Radha Ramnamurthy Gokula. He's an Indian physician Indian American physician who's board certified in family medicine, geriatric, lifestyle, and longevity medicine. Is the founder of Concierge Connected Care in Perrysburg, Ohio, and a leader in global telemedicine initiatives such as Global Teleclinics with focus on preventing and reversing chronic diseases. Dr. Gokula is the author of Live Well, 8 Habits to Health and Happiness, and the co-author for Live Well, International Disease Reversal Cookbook, Meal to Heal, both centered on plant-forward, evidence-based lifestyle change. His work integrates modern medicine with Ashtanga Yoga to help people reverse disease, cultivate daily habits for health and happiness, and age with vitality and purpose. So Dr. Murthy is a fantastic person. He's a great singer. He didn't tell you that, but he's also my mentor. He's the reason why I got board certified in lifestyle medicine. He's like, Pawan, you need to get this done. So thank you again for speaking on the behalf of API and educating us. And let you take over, sir.
Thank you, Pawan, for all the people who have attended on a Sunday afternoon. I'm really, really thankful and very grateful. And I really appreciate Pawan for the wonderful introduction. And I think it looks like I'm the last speaker for API for this year. And I guess I'm going to try to make it very interesting and very practical. I am preceded by two highly intellectual people, Kishore and Dr. Pawan. So I guess probably I'll try to kind of it'll be a hard walk for me to kind of walk in their footsteps to kind of keep it very intellectual. But my approach has been, I kind of say that I have two innings in my life, the first innings and second innings. I'm sure everybody knows cricket. So the first innings, I was a sick care specialist, where I was a family medicine, geriatrics, hospice, palliative medicine, and I was the program director at University of Toledo. I left in 16 because I wanted a holistic approach to health, and I got into lifestyle medicine just by fluke, my friend asking me to go because I went to Harvard for a CME course. And while I was there at 5 days, I literally felt all what they were teaching me at Harvard. My grandma, who was uneducated, was teaching me all those things, including she used to beat me up in my head all the time in a loving way. Chew your food properly, chew your food properly. Now there's actually a study comparing 20 chews versus 40 chews, and the average chews should be 30 chews for your food because that creates endogenous insulin. Endogenous GLP-1. So our Indians knew that. And that's why I was struggling to bring Ashtanga Yoga, which is nothing but 8 steps to health and self-transformation. But basically, if you look at the first 5 steps are about health, the last 3 steps are about happiness. And I do heartfulness meditation for the last 30 years. And I found my aha moment. And since then, my quest is, how do you blend lifestyle and longevity? Because after lifestyle, I got into longevity because I took over a practice. But I found that lifestyle can take you to a certain level. But if you address the hallmarks for aging, when you integrate lifestyle and longevity medicine, you can actually go to the root cause of chronic disease, which is about 80% of problems we see on a daily basis in medicine across the globe. And I think this is my first attempt to kind of start writing a book, create a course, and start educating people. And I've had wonderful response over the last 2 years speaking about this approach called Live Well. And my second is, now I'm a healthcare specialist. If you all want to note this down in your minds, we are doctors, which is DR. DR should be about disease reversal and not disease management. And the reason why this topic is very close to my heart is when I learned the statistic that every 5th diabetic on this earth is an Indian, it hurt my feelings. How from a society wherein we were using Sattvic diet to a point wherein we are now, and you can see what Dr. Panchavati has shown, that we are actually a global epidemic of metabolic syndrome, which is sooner or later. And my friend who is in Gujarat, a cardiologist, said that he's having to do stents for a 20-year-old, and it's sad. And when I did Adopt a Village screening program, 35% of the people didn't have a clue that their A1C was more than 6.5. It's sad. And we have 4 a.m. biryani now in India, which is totally sad. And we are kind of creating that epidemic. And I wanted to see how I can help using technology in order to change and create a paradigm shift in how we are actually approaching metabolic syndrome. I have no financial disclosures, but the part I actually mentioned this, the high clinical burden and disease modification. So my aha moment was that when I have, in 18, I had a high waist and I had poor lifestyle. When I learned things in Harvard, and I want you guys to kind of take a quick quiz. I have elevated cholesterol, and my family doctor says, I want to give you a statin based on the current AHA guidelines, and I refuse statins because statins, a third of people who are on statins end up with type 2 diabetes and other reasons that I don't like a statin. Can you all put in the chat which diet is evidence based that will help reduce cholesterol? I want the name of the diet will reduce. And Pawan, if you can look at it, see if there are any correct answers. And that's how I motivated Pawan, Satish Katula, Anupama Guttimukala to get board certified in lifestyle medicine. I hope all of you who are attending this call consider getting board certified. It's very easy test. Just have to do 32 CMEs online, go to the conference, take the test. It's a test designed to pass. So
yeah, I say Mediterranean, plant-based, but what you're looking for is not here. Low sugar diet, high fat diet, and protein diet, keto diet. Okay, keep coming. A lot of Mediterranean diet, plant-based diets coming. Whole food plant-based diet. Okay.
And I was also like you guys, I'm no different. I also gave the same answers. But when I went to doing the boards of lifestyle medicine, that's when I learned about a diet called portfolio diet. If you go to clinicaltrials.gov, it's 20 years ago, they funded heavily. And if you use portfolio diet, you reduce the cholesterol profile by 28%, and a statin reduces by 32%. There's no reason why, as a family physician, I must be giving a statin which has more harm than good. And you all know, I don't want to get this into a statistical discussion, numbers needed to treat, numbers needed to harm, and all that. I'm just giving you some things that I did not know and why I became passionate. And in my clinical practice, I did simple things and I reversed diabetes. So for the people who are pre-diabetic or diabetic, please, I'll tell you what Neil Bernard, who's a cardiologist, says. My goal is to kind of make sure that people understand what's the definition. Now you have definitions for remission, reversal, but reversal is a tough topic to kind of convince people because they start arguing. So American College of Lifestyle Medicine also has created this remission, and they're kind of trying to give guidelines. I think in my mind, when I blend lifestyle and longevity, these are the 8 drivers for cardiometabolic disease. And I'll tell you my framework. And I usually apply the 6 pillars of lifestyle medicine, which can help in a structured remission. And then Ashtanga Yoga, if you really practice well, it's a practical scaffold for habit change. And what's remission? The clinical definition is if the A1C falls below the diabetic range for a sustained period without glucose lowering medications, indicating not cure, but durable restoration of the metabolic function. If you see, Dr. Kishore mentioned about the ectopic fat that's accumulated around the pancreas and the liver, and that's the problem, visceral fat. If you look at what COVID did is, it was in a very inflammatory disease state. Then inflammation on a prolonged period will cause insulin resistance and cause increased visceral deposition. So the point is, I'm not here trying to say that I'm here to cure all the diseases, but remission is there's so much data now, you can completely reverse type 2 diabetes if you practically do everything that's needed out of you. But it will come back if you stop doing things. You really need an ongoing maintenance program. And it's now defined by international expert consensus. It's measurable, reproducible, and very clinically meaningful. For me, when I reverse diseases by simple things, which I'll give you, if you guys can, I don't have time for kind of too many, but I love to answer questions and all. But in my clinical practice from 2019, I've been practicing and I changed everything in my lifestyle. And 20, I got board certified. I can strongly say in these 6 years, I've been practicing lifestyle medicine in all my patients consistently. And if you do it structured, but what I've realized, and I'm a concierge doctor, people pay me membership money, but still half the people will listen, half don't listen. And for the people who really listen, I tell them, please stop these 6 things or move into. So I'll ask them to stay away from processed food. Any food that's produced in an industrial plant is processed. And for all the people, I'm going to make a full disclosure. I used to eat at least a dozen bags of namkeen probably in 3 to 4 weeks. And if you now, when I looked at in the back, you see palm oil. Palm oil is hydrogenated, free radicals. It's a disaster. Anything processed is a disaster because it causes inflammation and then subsequently other things. So sugar. I am a regenerative medicine practice also in longevity medicine. I actually use dextrose water with lidocaine and inject in a tennis elbow with some peptides. So that's called prolotherapy. So sugar is very inflammatory. Processed food, sugar, animal products. I used to eat meat like crazy. Now I've given up. Occasional, rare. And the reason is when you eat meat, it gets digested to form 3 things. TMAO. All TMAO is trimethylamine oxide, takes cholesterol and dumps it in the blood vessel, all the excess cholesterol. Then heterocyclic amines and activated glycated end products. And then yesterday, Dr. Kishore was also saying, oh, it also matters how you cook the food. And that's true, I agree. Based on grilling, the AGEs go up. Even if you grill tomatoes, it creates AGEs. But if tomato creates 60 AGEs, meat creates 600 AGEs. And then the other thing, it's called heterocyclic amines. Both heterocyclic amines and AGEs cause cancer. So you can see always the top 3 conditions in the United States that kill people is heart disease and cancer because we are a meat-eating nation. So why is reversal possible? Because type 2 diabetes, most of the people, I'll just ask, if you have to say there are 3 food categories, carbohydrate, fat, and protein. Can you just put which food type is actually the cause for diabetes? Just put it right and let's see what happens. Dr. Pawan, if you can just, after I finish this slide, if you can tell me what people said. So type 2 diabetes is a calorie problem. Once you have more calories.
Dr. Gokula, we're not seeing your slide actually. Can you share it actually? You're a co-host. I'm not seeing any slides.
Oh.
Okay. Yeah.
Uh-oh.
Yeah. Sorry, I was talking. Yeah.
Now can you see?
Yes, now we can see.
Oh, I'm so sorry. My apologies.
Yeah, if you can just go into the slides and just give a brief.
Yeah, so I have no financial disclosures. The topic matters I already discussed. And then the learning objectives are here. And what's remission is clearly stated in the slides. And why reversal is possible is because insulin resistance is basically when you have more calories. What happens is it gets, after you use the calories, the insulin takes the glucose, and once the cells are enough, the rest of the calories, they get converted to fat. And then the insulin takes that fat and says, what do I do with this fat? It needs to be deposited because it's excess. So it starts depositing all over the body and including the viscera. And then it happens that we eat so many calories that the cells, we call that intramyocellular fat, also gets deposited in there. And once they're full, it's like they're all full. So they don't want any more calories or they don't need any glucose. So when the insulin tries to take, as you keep feeding yourself every day in and day out, then the glucose is going up because the cells are not utilizing the extra glucose. Then the insulin goes up. Then the glucose goes up. Then the insulin goes up. That's your pattern. So, and that's insulin resistance for you. The way you do it is cut down the calories. Where do the calories come from? So did you see what people typed? of the three
Yeah,
food
I
types?
said carbohydrate diet, some have said fat diet, Dr. Shashank said carbs, Dr. Prabhakar said carbohydrate, high carb diet by Dr. Radhika Kohli, and the fat. So it's all like
Thank you. Thank
yeah,
you. People who said fats, you're right, because fat gives 9 kilocalories, carbs and protein give 4 kilocalories. I mean, I can go, we don't need to be arguing here, high glycemic foods and all that. I totally agree with you all there, but it's the calorie problem. Type 2 is a calorie problem. Cut down the calories. I'm not, I'm not again arguing with the genetics who are genetically predisposed. I can't do a thing. But those genetics, it's like everybody is born with certain predetermined genes. But what happens is your 6 pillars of lifestyle act as trigger. It's like a loaded gun does nothing, but you pull the trigger, you create harm. Same way lifestyle is create. So what I'm trying to tell is you can change this and you can improve the beta cell recovery and reduce the ectopic fat. And I've done this consistently. So when I use the 6 pillars of lifestyle, which are exercise, nutrition, stress management, sleep, addictions, and social relationships, I was getting to some point, and then I took over a practice wherein I had to adjust people hormones. I had to fix their guts. I had to adjust their hormones. They needed herbal medication, and I learned a lot. I would love for the audience here to put in the thing. If a person comes to you and says, you know what, I really don't want any medication to start, but I'm willing to take a herbal medication for my pre-diabetes or diabetes that's mildly elevated or impaired fasting glucose. Can you put a drug that works as good as metformin, which is a herbal medication and doesn't have any side effects? So then when I learned about anti-aging and I got board certified in 2024, then my aha moments came because I understood, and writing a book was my childhood dream, and I got into a business course and blended lifestyle and anti-aging. And then I made this live well approach wherein we link biology, behavior, and it's a coherent clinical framework. It's evidence-based. And then it's about habit creation. And for me, the best thing that was I was able to integrate Ashtanga yoga. And I want to bring back that into modern day medicine so that people will change. And there is tons of evidence and through that. But again, as I'm saying, it should be uh, patients with intensive lifestyle change, weight loss coaching, improved diet quality, physical activity, and higher rates are associated with higher intensity in change in lifestyle. But sometimes now it is much easier because you can have continuous glucose monitoring. Even if the insurance doesn't cover Dexcom, you can have people buy for $60 or $70 called Stelo, Stelo, and they can put it because that changes the behavior. So my classmate in high school, who is like runs a big engineering institution, when he wore Stelo, his behavior changed. Until then, when I was trying to put all these things in my high school WhatsApp group, people thought I was a nut because I was asking them to stay away from processed food, sugar, animal products, dairy, refined flour, and gluten. So dairy again is saturated fat. Again, there will be always discussions coming up. But that's separate. I'll be happy to answer on a one-on-one basis. But during the question hour, I can take some questions about all this. These I call the 6 poisons: processed food, sugar, animal products, dairy, refined flour, and gluten. White rice is a disaster because the more polished you make, you add more chemicals in that process, and chemicals cause inflammation, then insulin resistance. And then your sugar also goes up. The brown has B12 and fiber, and you'll have a slow spike. That's why when you eat beans, you have a slower spike. And then when you eat healthy fats too, like avocado or chia seeds. So I'm going to present some systematic reviews, 11 countries, you can't get a better one, non-pharmacologic multimodal interventions. And they did find that structured lifestyle programs deliver clinically meaningful remission, okay? And ACLM has a clear guideline that you can actually achieve complete remission in adults, and lifestyle, which are the 6 pillars. And in lifestyle, we actually give prescriptions. we create SMART goals, and we give fit prescriptions for each of the 6 pillars. And it is very structured and it's proactive. And that's why I call it healthcare, not sick care. And then what remission strategies, when they looked at it, is diet, physical activity, behavioral coaching. And I'll give you some, but the best evidence for remission or reversal is metabolic surgery. But how many people really want surgery? But if you don't have lifestyle, 2 years after, surgery is worthless. They go back. So, but there is now new data coming up that when you have a new onset diabetes or a early diabetes guy, you can do short-term insulin and quickly reset the beta cells. And then obviously now, GLP agonists are coming up, and rather I use chewing. And you can see, like, if you look at Europeans, I have patients who go to Europe, spend 3 months, and they eat the same way, but they don't gain weight, they actually lose weight. Because if you go to a restaurant there, you're going to eat lunch for 2 hours. I used to finish my 1 foot, literally, I'm not even kidding, I'm not exaggerating, 1 foot sandwich from in probably 30 to 60 seconds because I was in a hurry. When you eat in a hurry, there's a lot of issues. This is the evidence-based ELM trial recently for 24 months, published in JAMA too. And they actually looked at metabolic syndrome remission, 27.8%. Intervention was 21.2%. But the thing was, they really changed that if you create good habits and self-efficacy, it helps. So maintenance is also important. Simple habits, immediate feedback, and long-term maintenance are a key. In the interest of time, I'll be sharing all this. You can. But direct trial was the landmark trial that really helped patient that type 2 diabetes is achievable and substantial weight loss. For example, when you lose about 15 kilos, you literally get about 86% of remission. So it was tied to that. And long-term follow-up if you have a structured program. So for me, what lifestyle has taught me is that I'm not trying to be perfect, but progress. So that's why I tell, in lifestyle medicine, there's no failure, only progress. So direct teaches us, reduce the ectopic fat, and you can restore the insulin and the beta cell function, and you can help the way the body recover. And that's why, what does healthy means? Heal thyself. We were all born perfect when we were young babies. I mean, I'm not talking about the genetic issues that we inherit, but majority of them. But your lifestyle determines. So the lifestyle as cardiometabolic medicine, if you look at it, when you look at, so like for example, blood pressure, I don't look at blood pressure as a number. I look at it as at the cellular level, at the endothelial level, there is endothelial dysfunction because of immune dysregulation and inflammation. And then there is oxidative stress. And these are the 3 reasons. So I focus on that. And I tell people, hey, why don't you, if you're 140, 90, why don't you drink 5 cups of hibiscus tea? Because there was a study done, 5 cups of hibiscus tea versus captopril does the same job. So, but then Indians eat tons of salt and in pickles and everything. And that's where your other headache is. And then we eat a lot of fat, fried food, and then triglycerides. That's another problem. Waist circumference, lack of physical activity, compounds. And so this is the twin cycle hypothesis. I already talked to you about that. In the next slide, I'll show you what happens is if you don't have good dietary habits and no physical exercise, then you'll have increased calories, then leads to fat deposition in organ tissue, ectopic pancreas, which we're talking, then causes beta cell dysfunction. But if you do it right, then you'll have beta cell redifferentiation, improved beta cell function and remission. But again, the point is insulin resistance, if you fix pancreas, muscle and liver. So that's the reason it's very important that post-meal, if you walk every day, after every meal, you literally can see that your sugars are not going up and actually you'll get better results. And gut microbiome, we call that gut-brain axis, there is gut axis connected to everything, gut pancreas axis, gut liver axis, gut muscle axis. There is clear data, which I'll talk about like if I have, we call that butyrate producing bacteria. And the easiest way to fix gut is to eat whole food plant-based diet, sleep by 10 p.m. because 10 p.m. to 2 a.m. is when your body detoxifies. If you can't detoxify, you get inflamed and then leads to a cascade of insulin resistance and all that. So daily meditation. Don't eat after 5 p.m. And I'll give you 7 p.m. Sorry, because you need 4 hours to empty your stomach. So these are all simple things that I learned in lifestyle medicine, and that's why I encourage everybody. So my live well approach is the 8 drivers. When you look at lifestyle medicine, these are the 6 pillars which I talked about. No alcohol, sleep by 10 p.m., strong social relationships, daily meditation, manage stress, physical activity, health, whole food, plant-based eating. And if you look at the hallmarks for aging, until 2023, there were only 9 hallmarks. But in 23, they added chronic inflammation, dysbiosis, and one more, cellular senescence. So they actually divided the 12 into primary, antagonistic, and integrative. But that's the reason my live well approach has inflammation as the first one. And the easiest way to fix inflammation is move to a whole food plant-based diet, eat rainbow color foods, and minimize processed foods, and the 6 things that I asked you to avoid. Toxins. We live in a world of toxins, and toxins create a lot of, it's like choking a carburetor. Toxins do that, and smoking and alcohol are a disaster. Gut health, best, easiest way is to focus on fiber and fermented food, because remember I talked about the butyrate, the short chain fatty acids, they are all because of lentils, and Indians used to eat that way. Mitochondria, moving the body changes the mitochondria and improves ATP production. Insulin resistance, best is to improve the muscle. Hormones, the best is cortisol. For me, my problem is cortisol. That's why I have still some amount of midsection. And epigenetics, build daily habits so that you don't pull the trigger of the gun. Stem cells, yoga. There's nothing better than yoga. There's so much that you can do through yoga that you can actually create. So I blended lifestyle and anti-aging, came up with those 8 drivers. And this is my framework, wherein if you look at ethics is nothing but yama, which is Ashtanga yoga, which is what are the things that we kind of do, don't do, yama, niyama, discipline, asana, yoga, breath, pranayama, tons. There is so much evidence linked to toxins and other things apart from that. But I'm just saying, pratyahara, the lifestyle, be aware of it, focus, then you can, mitochondrial function, dhyana, when you have total samadhi, which I call, which is eternal bliss, really it's parasympathetic dominance. When you meditate, you have significant parasympathetic dominance that really changes the gut. Remember, the gut has the vagus nerve that connects with the brain, and that helps the gut. So, and then my 8 habits are, you need to change your mindset, that I can do this, I'll do it for my own health. And that's what I did. I didn't do it for other people. And then my why was, I know how older adults live in this country, and my life is not going to be any different. I want to stay young and die young, wherein I have optimized function and quality of life. And that's my why. And then goals. I have goals so that I need to have a flat stomach by the end of this year. I observe myself every day, do what I'm doing wrong. Not that I'm perfect. I'm not perfect. And I act, I learn, reading more, create some disciplines, and I overcome. And now I'm speaking here to inspire others, transform, and attract. And that's called My Goal, Do It. So this is just my framework. And I'll talk about how inflammation can exacerbate insulin-resistant vascular risk. How much time I have, Dr. Pawan?
Yeah, Dr. Murthy, you can go for 5 more minutes, and then we can
Okay.
take 30 minutes
So,
of call.
yeah, so so you can see here clearly, I put it there for you to understand that inflammation reduces visceral fat, then sleep by dampening the inflammatory signaling. Remember, I said 10 to 2 is where your body restores. Sleep is the best regenerative medicine that you can ever get. So please, and then why did I become passionate about this is when you get postmenopausal, your progesterone drops and your sleep gets messed up. just giving progesterone, I've created, I mean, people come to my office and they cry because they've not been able to sleep for the last 10 years, taking all kinds of stuff, doing all kinds of things. When I just fix their hormones, they're sleeping like babies, So limit ultra processed food. Mayo Clinic clearly did a lot of studies, put systematic reviews too, and that your risk when you eat processed food increases by 5 times of mortality. So insulin resistance, there are several ways you can check HOMA-IR quickie, triglyceride and HDL ratio. That's what I use to kind of explain patients. I calculate HOMA-IR too, and there is toxins. I really push people not to smoke and drink alcohol. Alcohol is very inflammatory, and then the problem is they and tobacco also. And the point is, along with the plastics, with all their we call that EDC, endocrine disruptors, then they cause toxin accumulation and difficulty. And hormones are really critical. Cortisol is one thing that it actually raises, and visceral fat accumulation and insulin resistance. And appetite hormones, sleep deprivation can increase ghrelin, lower leptin, overeating, and poor food choices. Here, I'll give you a hack. Whenever you feel like you're craving for something, first start drinking water, and then see if you still have the craving. When you really crave for something, it's usually body saying, I'm really dehydrated, please give me some water. But instead we go for processed food. That's a quick diet. I mean, quick snack, namkeen and all, we mess up our life. Hormone regulation may support both initial weight loss and long-term remission. So I have fixed people's hormones, and they really kind of change the game. Gut health, I'll kind of short-chain fatty acids, bile acids, inflammatory single, the 4 cups. In this country, they push protein. A female needs 46 grams of protein. A man needs 56 grams of protein. A tur dal has 15 grams. So man can eat 4 cups, 2 cups in the morning, 2 cups in the evening. Women can eat 3 cups, and then they'll be all fine. Because I wanted to show how fiber-rich food, Faecalibacterium prasunitzi. I see this because I do gut testing, anti-inflammatory, Roseburia rumenica, Cryptococcus butyrate. They heal the gut, Bifidobacterium. I see a lot of people with no Akkermansia at all, but this is the one. What happens is, if the gut breaks, then LPS, we call that, and then you see that they create intestinal gut leakage or intestinal gut barrier leakage, and then the toxins are released, and that's how they create inflammation, and then reduce insulin sensitivity, and then change the liver and pancreas. So it's very critical that we fix the gut dysbiosis. And the easiest way is to fix the gut is to whole food, plant-based diet, exercise, and fix your lifestyle. Epigenetics, especially the exercise and nutrition and mindfulness. So here I want you to guys watch a movie called You Are What You Eat on Netflix. Stanford did this study in twins. Wonderful study. And please watch the Netflix movie called Blue Zones. You'll understand. And I gave you some resources. Please look up those resources. And epigenetics, you can really change lifestyle and fix the glucotoxicity and the lipotoxicity, and you can normalize. And mitochondrial dysfunction, it's like the ATP production. So when you can't really optimize, then there is reduced metabolic flexibility, I call that, and then the oxidative capacity, and then people have issues. They feel tired quickly, and the reason is because you're not able to produce enough ATP. So it's important that you take care of mitochondrial function. So your plate should look like this: minimally processed food, high fiber intake, and then again, as I said, there is actually some 10 hacks that I'm going to kind of show you how you can actually do your hacks for as a take-home message, along with the slides I'll give it, that you can do for yourself, which is start eating veggies first. Because remember, the more you chew your food, because vegetables or salad, they take time you got to chew chew them properly. So your GLP produces, taking time to eat, mindfulness eating. Then after that, eat your rajma, lentils, and then last eat carbs. This simple has shown that how, and then walking immediately after the meal. These are all the hacks that I'll share with you guys. Refined carbohydrates are a disaster, fiber, and so how Ashtanga values, wherein you can say, Yama, reframe food choices for self-care and health preservation. Eating becomes an expression of values, not restriction. Pratyahara, central. So help patients slow down, recognize hunger, fullness cues, interrupt automatic or emotional eating patterns. This was all clearly stated there. Physical activity, asanas. The standard suggestion is 150 minutes for aerobics, 2 to 3 days. I would rather say for somebody like us, we don't look like this, and I've not seen an RP guy look like this, including myself. The best thing is to just do resistance training 5 times along with aerobics 5 times, and then you'll have great help. Because sarcopenia is a disaster for when you want to be independent, even when you're under the deathbed. Asanas are really the way to go, because asanas, pranayama, mudras, they all have tons of evidence. I can happily share the evidence of Ashtanga yoga in modern medicine for all these things, if at a personal level. Restorative sleep, it's not an option. Sleep is metabolic therapy, and in my mind, it regulates appetite, insulin sensitivity, and hormones. It's really the best way. And the niyamas is sleep hygiene, pratyahara, and yoga nidra really shows all that. The stress management, we do meditation, helps cortisol, autonomic balance. And when you're stress-free, it has shown that relapse changes. So from just being reactive to regulated way of living life by pranayama, dhyana, and pratyahara, you can actually create all this self-regulatory and improve your body to heal by itself, because we are the wonderful machine, and I don't think anybody still fully understands the whole concept of how at the cellular and metabolic level we function so perfectly. Social connections are a critical piece especially as you age, because they have significant effect, and a lot of times stress and social functions are not really focused. Studies have shown that I ask everybody to go back to their childhood days and call one of the friends that they never called in their entire life, find them somewhere or call, and then start talking. You can pick up the phone or go and meet them. Now isolation in the elderly is becoming increasingly rapid, and people are getting socially isolated. It's called loneliness syndrome in geriatrics. So substance avoidance, tobacco cessation, alcohol, environmental exposures are disaster. So if I have to put it as a complete behavioral and change framework, yama, which is values and food choices, niyama is routine, sleep, and others, but habits. Asana, movement, pranayama, breath, stress, and sleep. You can do box breathing called 4-4-4, 4-7-8. They all help. Pratyahara is sensory control and mindful eating. Dharana is focus and consistency, trying to focus and become mindful. Dhyana, meditation and stress. Samadhi is your identity change and long-term maintenance. So these are some of the ways that you can calculate for the benefit. Then the best people who benefit from remission: newly diagnosed diabetes, central obesity, metabolic syndrome, marked insulin resistance. I try to keep fasting insulin below 8 and A1C below 5, because each time A1C goes up from 5 to 6, you have approximately 3 to 11% of mortality increase. So I don't care about what the diabetes definition of 6.5 and above. I care about being proactive and cutting it down, and deprescribing as the patient changes. I stop pills, and I've done successfully. It takes time, it takes patience, but can be done. So this is how we create SMART goals: specific, measurable, achievable, relevant, and time bound. And they'll say, I'll eat vegetables at lunch and dinner 5 days a week. Not, I'll just eat healthier. They'll clearly commit to, I'll walk for 20 minutes after dinner on weekdays, because that supports glucose control. Time bound. I'll try this for 4 weeks and review with my doctor at next. So SMART goals are like fit prescriptions. What's the frequency? 5 days per week aerobic activity. Intensity, moderate intensity, repetitions. So this is how we give prescriptions to patients in lifestyle medicine. Time, 30 minutes per session, which can be divided. And then type, we describe the type that they like. So exercise becomes a happy occasion and not. So we do group visits because that helps education, accountability, and shared momentum. And group visits are, you can bill 99214, and in a half day, if you see 10 to 15 people, that's a lot of money also. Financially also, it's viable. And our own Padmaja Patel, who has been the ACLM president, has pioneered this in healthcare systems to create improved, she has an Institute of Lifestyle Medicine where she works in Texas. So patient communication is also important, how you say, because when you say cure, FDA comes after you, but we'll say evidence suggests remission may be achievable for some patients, your biology will improve, and then small daily habits. So that's what we say. And then there is a science called motivational interviewing, because if you look at the science of habit change or change, then there is pre-contemplation, contemplation, action, maintenance, and relapse. So when you're pre-contemplation, contemplation, motivational interviewing helps. For the rest of it, cognitive behavioral therapy works. So it depends on the patient how we do. So the 5 daily hacks to flatten your sugar, this is taken from an article directly published. Low carb and balanced meal. As I said, eat first your veggies, then your protein, and then eat more carbs earlier in the day, breakfast and lunch. And don't do late dinners after 7, because gastric emptying is 4 if you. And then when we eat late dinners, digestion is a sympathetic process. If you see the circadian rhythm, we are going into the parasympathetic mode in the night to sleep. And then now suddenly you're waking up, and then the body doesn't understand. It digests the thing because you have dumped it, but then creates a lot of inflammation. Even regular digestion creates inflammation. That's why it's called inflammaging. But the point is, you can hack this. Vegetables first, protein first, and carbs last. Slows gastric emptying and reduces post-meal glucose surge. Walk after meals, turns muscle into an immediate glucose sink and lowers postprandials. So personalized glucose monitoring. Now it's available over the counter, and then each person reacts differently. So it's better they understand their thing. So Neil Bernard, who's a cardiologist, says, if you want to reverse diabetes in 3 steps, first, stop all the animal products. Anything that comes from the animal, it is animal product. Cheese, dairy, paneer, whatever you call. And in this country, let me tell you very clearly, every cow that's giving milk has a tag on the ear that's hormones, and they all get antibiotics to prevent what we call that uderitis. And you're literally, if you look at, humans are the only animals that drink milk. That no other species drinks other animals' milk. So they are meant for the babies. They themselves have hormones. Plus, these people are giving hormones to bulk up the muscle, to improve the udders, and then they transmit in the breast milk, plus the antibiotics. So that's why you have a screwed up gut in this country, and everybody has gluten intolerance. And India, when we had famine, they actually modified genetically, and that's what we're eating, genetically modified gluten. So these are the 6, I call them, things to change from processed food to whole food, plant-based diet. Instead of sugars, eat fruits. Instead of animal products, try to eat a lot of lentils, and if gluten-free, dairy, non-dairy milk like soy milk, refined flour, use whole food flour. So it's very simple. For lean diabetes, food, sleep, movement, stress, if you focus on this, you'll get the bang for the buck. If you really want 2 books, Kick Diabetes. These are wonderful books. This author has actually done a statewide study and reduced diabetes in Hawaiian population. So, but the apps you can download, Daily Dozen by Michael Greger. Dr. Greger wrote wonderful books called How Not to Age, How Not to Die, How Not to Diet. And these are the key articles that you can look at. And thank you for this opportunity. And I'm excited to take questions, because I can talk more on a one-to-one basis if you have any questions.
Yeah, thank you, Dr. Murthy. That was an excellent talk. So, the question is, I want to go a little bit because, I'm trying to go in an order, but let's take this question which came towards the end. So it came after your talk, which says that all sounds good, very well, and we're all aware of it for a long time, but everyone has different work hours, lifestyles, and stresses. Even if one wishes to do all the right steps, there are issues for following it always. My goal is if I can follow 75 to 80% time, I'm doing better. The other issue is levels of blood sugar, BP, cholesterol, hemoglobin A1C are lower, which should be different for young adults and elderly. So, what are your thoughts about it?
Oh, absolutely. There are clear guidelines. There is data for an elderly patient. If you jump it down two to like what I said, five, sometimes they can't tolerate. So I have patients who can't tolerate 120. Anytime I put it to 110, they go into hypoglycemic. So, but again, their body is preconditioned. So if you slowly change their lifestyle. And I like the 80-20 principle because I talked to one of Indian origin. She's an ABCD. She has all the money funded trials for preventive cardiology. She said, Murthy, on a long-term basis, you cannot win the game. People go back to their habits. You just be happy if they're doing 80% of lifestyle and 20% they have the freedom on special occasions that they can do what they want. So lifestyle modifications must not be a curse or imprisonment or a punishment. It should be a joy to celebrate your life. I totally agree. For elderly, there is different A1Cs that you need to look for 90 years, probably 8, for 80 years, probably 8. I mean, and then 70 but I'm just talking about young people because Dr. Kishore talked about lean diabetes and you talked about the metabolic syndrome. I want to address to keep them because like for example, there is prospective studies that they have done. If you really never want, I mean, never is never, right, in medicine, but if you want to really prevent yourself from having a heart attack and stroke in your life, keep the LDL at 70, total cholesterol at 140. Then the same way, A1C, if you keep them below 6 all the time, your odds, because as you know, it's a coronary disease equivalent, right? So the more you drop and the each rise, that's what motivates me to keep it low. But I do agree with Dr. Gupta, what she said, that age must be taken into consideration.
Okay, a couple of things. People were asking me, how do I get a CME? So after this, meeting, you'll get a email from the EMED events. So once you fill the survey, they'll send you a CME certificate link, and you can download it. And it also they have their own vault, which it downloads for you once you create a login. That way, you don't need to search it again and again through your emails. Okay, so Doctor, somebody said, can we have slides? I said, Dr. Kishore, and I'm okay with it. I assume that Dr. Murthy is also
Oh, I
okay.
have happy to give my slides.
So can you send? I sent an email. It's to Vijaya Kodali, vkodali at rpusa.org. Okay. Uh, I am typing it again in the chat. So please email her and we'll email the presentations. That way, she can send it to you. Right. So, there's one more question, Dr. Alka. Yeah, I have it. So she says that, somebody developed a type 1, insulin dependent diabetes mellitus after immunotherapy in a pre-diabetic patient with a hemoglobin A1C of 6.3, right? And they also developed pancreatic exocrine insufficiency, and they're having problems, controlling the glucose, it's going up and down, is there a process to reverse it? I think, too late in the game, but probably need an insulin pump at this point, and then, can you, Dr. Kishore, can you share some thoughts on this? And then Dr. Murthy can.
Yeah, I have some thoughts to share on type 1 diabetes after Dr. Kishore finishes.
Can you repeat the question, Dr.
So that question
Pachawadi? I
is
was
that
reading. I was reading
assuming,
some comments. I
yeah,
lost
I am
track.
assuming that, Dr. Patel said, she said there is an insulin-dependent diabetes mellitus somebody developed after immunotherapy. I'm assuming it's the immunotherapy for COVID, I think, in pre-diabetic patient with the hemoglobin A1C of 6.3. They also developed pancreatic exocrine insufficiency. So they want to see, what your thoughts are, and then Dr. Murthy can,
I
go
mean, COVID infection itself can cause diabetes type 1, and we don't know what type of immunotherapy they got it. Depending on the drug, if it has a adverse effect, and the pancreas can be easily affected by several drugs.
Oh,
That's
she
how
said
the
Keytruda induced. So can you type in, Dr. Patel, why was the Keytruda given?
Keytruda, I
Yeah,
don't know
yeah.
what it is.
Keytruda is an immunological. We use it for maintenance of cancers and also immunotherapies. Oh, lung cancer stage 3.
Okay, and then it's more complex than to say whether it is due to the COVID or drug.
Yeah. Okay, so let's try to get it, Dr. Murthy. Can you go in and say, for some unfortunate reason, this person developed a insulin-dependent diabetes?
Yeah, I can talk about type 1. There is clear data if type 1 people really practice strict lifestyle modifications, their insulin requirements drop by 50%. Okay. Second, for the people who have immune mediated beta cell dysfunction or destruction, we check their C-peptide levels. And if they are really low, we check their insulin levels. They're low. And they're really struggling with all the complications, let's say for diabetes. Since I'm in the regenerative space, there is data that stem cells that Dr. Bellamkonda also talked about, exosomes, which are signaling molecules, and some peptides, which GLP-1 is a peptide. You can literally kind of help restore, because GLP-1 not only does what it needs to do, but also, as I said, it also changes the amount of visceral fat around the but again, when you have immune mediation, there is significant inflammation, then gut dysbiosis. So for them, I look at this whole approach so for example, I do ozone. It's a total different product, but ozone attacks inflammation and then attacks the mitochondria by increasing the NAD/NADH ratio in the cell wall and improves the ATP production. So you need an integrative approach for these people. But stem cells, they have done stem cells that are taken out from, which is controversial again, from the animals, and then close to it is rabbit. And they have done studies on that, and they have reversed type 1. And there is their own stem cells that you can take from the fat, or they can take mesenchymal stem cells, exosomes. And now we are having what is called mu cells that you can do, and there are protocols that you can use to help fix. I'm not saying that I can reverse type 1. No, I'm not saying that at all. But they have helped these type 1 diabetes people to restore their pancreatic function better, and then regenerate some of the pancreas that's attacked by the immune system. But again, I feel very good. You know why? I do PRP and peptides in my clinic for a lot of musculoskeletal issues, and I go to these regenerative medicine conferences. Everybody, even anti-aging people, are talking in the last 2 years about lifestyle. I made it a conscious choice. I prayed a lot. I meditated a lot. I said, I'm going to practice medicine like this for the rest of my life. It is the key. Eating whole food, plant-based diet. Indians were the masters at it. So if I may continue, even though I wanted to give the 10 things to do every day, walk 10 to 15 minutes after each meal, stop eating 3 hours before bed, fasting, because there was a question, Dr. Pawan, intermittent fasting, which
Intermittent fasting. Yeah, I'm going to come to that. Yeah, you can answer it. That's fine. You're on
yeah,
here.
because intermittent fasting, it's funny because they have done so much of work on that. And our people were normal. My grandma used to say after 7, don't eat any food. And then the breakfast was after 7. To 12 hours, we had fasting just listening to my grandma. So, and then they have done 12, 16, 8, 24, weekend fasting, all that. Time restricted helps. But in that eating window, it also matters what you're eating. If you go and eat McDonald's and eat burgers, and if you eat all that, it's all worthless. It doesn't help at all. So that eating, the reason intermittent fasting helps is improves blood glucose and insulin sensitivity in type 2. Eat vegetables first, protein second, starch last. That helps glucose absorption and blunts post-meal spike. Build your meals around beans, lentils, vegetables, nuts. How much nuts? 8 to 10. Which are the best nuts? Walnuts and almonds. Seeds, chia seeds. Chia seeds have omega-3, and then they fill up. They have a lot of fiber, intact whole greens. And then there is a discussion about lectins and gut and gas and all that stuff. The best way is to eat skinless lentils, soak them overnight. Next day, use your grandma way of cooking it in an open pot and then drain off the fluid. Your lectins are gone 98%. Sugary and ultra processed. Do resistant exercise most days because that's the best way. It's a glucose sink, I call that, muscle. So strength training helps pull sugar out of the blood. Sleep consistent 7 to 8 hours of sleep. Practice 10 minutes of breathing, meditation, or yoga. Track weight, fasting glucose, and one lifestyle habit a day. So that's what I say, the 10 things to do.
Okay. So the thing is that somebody wrote, good brown rice. What brand and what glycemic indexes? You have any
Yeah.
link for it for
Yeah,
us?
I mean, don't. I mean, now actually India has come up with, I don't know who came up, low GI index rice. I don't know what that means. Just eat whole brown rice, okay? Because it's got fiber in it. But again, eating too much rice is a problem because it's carb. Eat little bit of it, but eat more veggies in there. You know, we have changed the pattern. In the past, when Sattvic died, they used to eat a lot of vegetables and there was a little bit of rice, on the side. But things changed. We started, especially in the south, so then the glycemic index of the foods is real. That you focus on low glycemic. For example, some people they eat grapes and they eat mangoes. They're all high glycemic. It shoots up, but that's the reason you should eat fiber first. But it may shoot, but it'll come down. But the point is, if you eat junk, that's where the problem is. Fry food, that's a disaster. So brown rice is enough. It doesn't matter what it is. Quinoa is great. If you really want to focus as Indians, millets are the best.
Okay. So, I think, what do you recommend for vitamin D sources if we are avoiding dietary? I think Dr. Kishore answered it, So, if you can go through the
Oh,
chat.
yeah. So I want to answer this. Please download the app Daily Dozen by Michael Greger. Put your question in that. It'll answer you. It's a thing that vitamin D is in milk and calcium is in milk. It's all a myth. Okay. A cup of almond milk has 450 milligrams of calcium. Yes, vitamin D, I understand. But in the past, we used to be in the sunshine. But now I'm in the Midwest. Half the time I don't see sun at all. So it's a problem. So I supplement. And Dr. Kishore clearly said B12, vitamin D are critical. It's better to supplement. The reason egg yolk and mushrooms are great. Egg yolk has 300 milligrams of cholesterol. And I try to kind of stay away because a lot of us have lipid issues because that's how it all starts. Little bit of cholesterol problem. Then after that, then you get hypertension. Then you get pre-diabetes, then diabetes, then heart disease, then stroke. This is the pattern that you do. And yes, there is data clearly that if you completely do whole food plant-based diet versus meat-based diet, the muscle bulk reduces in whole food plant-based people. But that's the reason resistance training is critical. If you look at Jackie Chan, Arnold Schwarzenegger, Williams, Tony, who is that? Tom Brady. These are all whole food plant-based people.
Okay, this question, autoimmune pancreatitis in a 20-year-old child, diabetes like hemoglobin A1C 6.5. Can we reverse it? I think so.
Absolutely. I'm not saying 100% again, but you need to understand why you get autoimmune issues. The first thing is terrible inflammation. It could be stress in that little girl. You need to take a strong social history. What happened during their child? What were their lifestyle patterns? So and then I check for thyroid, autoimmune thyroid disease and all. So then I check for the gut. You can just do a gut microbiome. Genova for $430, they'll do a gut microbiome and I fix the gut. So you can't just attack one thing. You got to address all this. Check for toxins, check for hormone issues. But usually it's gut dysfunction. 80% of your immunity is in the gut. Once you have gut dysbiosis, you have autoimmune changes, and then you get then it starts attacking whichever is vulnerable. And in this, unfortunate, it's pancreas. But if you see a functional medicine specialist, there is a way you can start looking at it as a holistic approach, and you fix these people. And like, for example, in my practice, when I have autoimmune diseases, I use what is called low-dose naltrexone. So naltrexone, regular MDs will say, oh my God, that's a drug for alcohol addictions, drug addicts and all. But if you look at LD and low-dose naltrexone, which is 6 milligrams and below, I start at 1.5 the first week. Next week, I give 3 milligrams and increase it to 4.5. Most people settle there. It is a very, very good anti-inflammatory, very good immunodysfunction. And then gluten. In this girl, I would just, for everybody, I fix the gut in autoimmune problems, and then I make them eat a lot of raw vegetables or like slightly cooked vegetables, and then I fix their gut, low-dose naltrexone. A lot of times you'll see a lot of good results.
Right. So, there's, they were saying that what's the deleterious effects of diet sodas and energy drinks. I think Dr. Kishore answered it. Yeah.
Yeah, somebody actually gave the good answer there already. It's that, as I said, processed are a disaster. It doesn't matter where it is. I'll tell you where I got this disease reversal kick was, there was a CEO in Dayton who called me saying that I have psoriasis. I went to Mayo Clinic. I'm on TNF inhibitors. Every morning I have simple arthritis. I said, his wife was on the phone. I was going to India to the airport. I said, I'll send you this one page, and I'll be happy to share that page with you, with Vijaya, and she can share it. So I said, stop these 6 things, which I just told you guys: processed food, sugar, animal products, dairy, refined flour, gluten, And then I said, eat in the green zone, don't in the. And then guess what? In 2 weeks, his psoriasis disappeared. When did it come back? I didn't know this guy smoked a cigar and then alcohol, because I didn't take history. I just told. So that's when he figured that, okay, smoking and again alcohol brought back his skin condition. So that's what I'm trying to tell you. They are very inflammatory, smoking and alcohol. So psoriasis is an inflammatory problem. So it's very critical that you understand this basics. And that's why I became emboldened. Doing these simple things, people were like calling me saying that I'm better, I'm better. Can I do 100%? No. You got to look at the holistic and an integrative approach.
Okay, so the next thing I think I can answer it, since coronary artery disease starts at an early age, most Indians have subclinical coronary artery disease, which we agree by 40 or 50. Are statins of use these patients, and also for those who have already coronary artery events, stents, etc. Again, the thing is, the lifestyle, as I told you, is a powerful tool. It's not like it's a powerful medicine which we ignore. We think, okay, he's telling exercise, he's telling this, diet and all. I think first line, I would go with that for subclinical people. And then, if needed, we probably need statins. Right. So somebody asking, how do you fix the pancreatic exocrine insufficiency after Keytruda? Again, Dr. Murthy, you have any questions any thoughts on that?
Oh, yeah. It's very simple. When I do a stool test and then I do another test called Nutrival by Genova, it'll actually give me what is the mitochondrial dysfunction, what is the oxidative stress, what is the omega-3 index, what is the nutritional status, what are the toxins. I go at the cellular level for all the vitamins and all. And it'll give me whether there is pancreas elastase problem or IgA elevation. And then you give digestive enzymes, And I actually had a patient, young lady suffering, went to University of Michigan, the top institute, and I was trained there too in geriatrics. And she was not getting better. When she came to me, she had cholecystectomy, and putting it all together, she used to have pain with food. When I just gave her digestive enzymes with some betaine HCl, her problems are all fixed. So the point is, it's not like it's different strokes for different people. That's why, still history and physical, the review of systems, you put it all together. Yes, exocrine pancreatic syndrome, digestive enzymes. There are plant-based also, ma'am. There is a website called Full Scripts. Any doctor can register, go in there, and you can see for yourself all the supplements that you can order. Cleveland Clinic uses this platform. the supplements that you buy over the counter, it's a disaster in my mind, because they've done studies and half the time you don't know what contents are there. They're missing contents. Full scripts, FULL scripts, SCRIPTS. So that's what most functional medicine, integrative medicine people use. I can put it in the chat, full scripts. You guys can go, anybody, doctor can use that.
Okay, Dr. Murthy, in the interest of time, I think we are at time.
Yep, thank you.
Thank you. And, thank you, Dr. Kishore. Thank you, Dr. Murthy, for
Thank you.
this excellent talk. And we thank API, Dr. Amit Chakrabarti, Dr. Vasauda. And, two things is, please fill out the email survey, which will come from EMED events for your CME certificate. And we will definitely send all the CME presentations to Vijaya. Please email her for this, and this will be recorded. This is being recorded actually, so you can get this whole again, the whole video of whatever we did, the recordings, in the RP website soon. Thank you again. Yes.
Pawan, one solid last question. Somebody said, do you have concerns about glyphosate in plant products? Yes, pesticides are a problem. Here's the evidence. Soak them in baking soda for 15 minutes or vinegar, but the best evidence is for baking soda. For 15 minutes, wash them off. 98% of them are gone, so you can be happy. Thank you. And thank you for this great opportunity, and I'm glad. Thank you for all the people who attended.
Yeah, thank you. And we have to tell
Thank you.
that we're going to do something like this in the National API coming up on July 2nd. If you're in Tampa, July 2nd, I think the whole team will be there and we'll come up with practical hands-on workshop there. Thank you again.
Thank you.